Good evening. Welcome to BMT InfoNet's Ask the CAR T-cell Experts. My name is Michaela O'Brien, and I will be your moderator this evening. Our panel of CAR T-cell experts will be answering questions that registrants submitted in advance, and we will answer as many questions as possible this evening. If you do experience any technical issues with your audio or video during the event, please use the chat box in the lower left-hand side of the screen, and a technical support member will respond and resolve the issue. Tonight's live event is being recorded and will be available soon on BMT InfoNet's website. We will send you an email with this when this webinar is ready for viewing. It's now my pleasure to introduce our panelists. Dr. Deanna Cirstea is a hematologist-oncologist at the Mass General Brigham Cancer Center, a faculty member at Harvard Medical School, and part of the Massachusetts General Hospital Multiple Myeloma Program. She is an expert in CAR T-cell therapy for patients with multiple myeloma. Dr. Jay Spiegel is an assistant professor at Miami Miller School of Medicine and a hematologist in the Transplant and Cellular Therapy Division of the University of Miami Sylvester Comprehensive Cancer Center. He is an expert in CAR T-cell therapy for patients with B-cell malignancies such as lymphoma. Ms. Margaret Franzetti is a licensed clinical social worker who specializes in supporting individuals and families affected by blood cancers with a focus on CAR T-cell therapy survivors. She currently facilitates BMT InfoNet's CAR T-cell therapy support groups. Let's begin with questions we received about what's involved in undergoing CAR T-cell therapy. All right, our first question is, please describe the steps involved in undergoing CAR T-cell therapy. Dr. Spiegel.
Sure, thanks. Just to start at the beginning, I'll just give an example of a patient with lymphoma. So if your lymphoma physician determines that primarily that your lymphoma has relapsed either after one or several lines of therapy, depending on the type, and that you qualify for CAR T therapy, if that physician can give CAR T therapy, they will initiate the process, but sometimes they will refer you to either an academic center or to their colleague in the Transplant or Cellular Therapy Division to begin the CAR T process. So there might be some time before you see the physician that's able to prescribe the CAR T therapy. Once you meet that physician will have to submit for insurance. So we need insurance approval before we're able to go forward with CAR T. Depending on the center that you're at, that can take a shorter time or a longer time. I would say about 2 to 4 weeks. So if there's some lag time before you see the initial physician, some insurance lag time, that might be a period of close to a month before you undergo the first step to actually make the CAR T, which is called leukapheresis. So a CAR T depends on taking your own T cells from your body with a procedure called leukapheresis. It's a machine that looks like a dialysis machine, a 4 to 6 hour outpatient procedure that the patient requires either a placement of 2 peripheral IVs or a central line. That's an outpatient process. 4 to 6 hours, the cells are collected, sent to a company that will then make the T cells into CAR T cells. That period of manufacturing can take either 3 to 5 weeks, depending on whether we're talking about lymphoma or myeloma CARs. And during that time, if you have a disease that needs therapy, your physician will give you either chemotherapy or perhaps some targeted therapy. Then, when the cells are ready, your center will bring you back for outpatient, what we call lymphodepleting chemotherapy. This is to prepare your body for the CAR T cells to be infused. That's 3 days of 2 chemotherapies, typically fludarabine and cyclophosphamide. That's usually about 5 days before the CAR Ts are infused. Then patients, when that is completed, the patients on day 0 will have the cells infused either in the inpatient or outpatient setting, which we'll talk about in a bit. So all in all, from the time that somebody decides you need CAR T therapy till infusion is about 2 months, give or take.
What are the most frequent side effects of CAR T-cell therapy, and how long do they last?
Sure. So just for this, I'll focus on the more acute toxicities. So the first is that when you have a flu, for example, and you feel pretty terrible, flu, feverish, achy, that's actually your immune system kicking off to get rid of the virus. So similarly, when we put in these CAR T cells and they go and target the disease, lymphoma, for example, they're going to release the same chemicals that your body is releasing when it's fighting off the flu. Those are called cytokines, and they can cause fever and feeling quite poor. That's called cytokine release syndrome. Typically manifests as a fever at minimum, but can have other symptoms like low blood pressure and in real severe cases, which is quite rare, some lung damage and even patients requiring to go on a breathing machine. That happens, I would say, less than 5% of the time, maybe about 1 to 2% of the time. And that typically onsets within the first 2 to 5 days after the cells are infused. Now, those same cytokines can also go to the brain and cause neurotoxicity, which I think when people read about CAR T is the type of toxicity that worries them the most. This usually comes on several days after the onset of cytokine release syndrome. It's usually can happen concurrently, but usually several days after, so maybe a week after the cells are infused. That can manifest in a variety of ways. What we call grade 1 neurotoxicity is just some confusion. So we ask you several questions over and over again. And if you miss some of those questions, like what the date is, you might be having grade 1 neurotoxicity. Grade 2 is usually difficulty talking. It may appear to be a stroke, but it is not a stroke. It's a difficulty with attention, like word finding difficulty. Higher grade toxicity like grade 3 neurotoxicity can be either difficulty staying awake, what I like to call lights on, nobody home. So the patient is awake and in bed, but not tracking, not really interacting with the outside world, or a seizure. And grade 4 can be either multiple seizures or a coma. Now, the percentages of these toxicities depends on the disease you're treating, as well as what type of CAR T is selected. So there's a little bit of nuance there. But I would say in general, the rate of CRS is anywhere in the 50 to 90% range, while neurotoxicity for the axi-cell type, more aggressive type CAR is about 20 to 25%, and with the 4-1BB more lysocell-like CARs in lymphoma, around 10%, and with the myeloma CARs is certainly a lot less as far as severe neurotoxicity.
How long is a patient hospitalized for CAR T therapy? And can it be done as an outpatient procedure?
So I'll answer that backwards. Yes, it can be done as an outpatient procedure. It really depends on the center and the setup. So for example, here at my center, we do most of our CARs inpatient, just where our patients are coming from, and their caregiver status. A lot of the time it's easier for us to admit the patients, but I think most centers are trying to move to an outpatient model. Patients like it better. It's easier to manage if you're able to be at home or at least not stuck in the hospital. That said, patients can start off in the outpatient setting, but if they are to get the onset of cytokine release syndrome, will often be admitted to the hospital. So even if you start outpatient, you oftentimes will end up inpatient. Inpatient typically used to be for a minimum of 7 days. Like I said, if you're starting outpatient, that might be a tad less. But on the whole, minimum of 7 days and typically about 10 days, at least here.
Dr. Cirstea, how long do CAR T cells survive in the body?
Hi, so before I start, I just want to say that I'm thrilled to be here, and I'd like to thank the audience for being with us and having this interest in CAR T. So I'd like to say that In multiple myeloma, the presence of CAR T cells in the body varies by product and by patient. But generally, it ranges between a few months and several years. You know that we have two CAR T approved products in multiple myeloma, and those are Cilta-cel and ide-cel. So Cilta-cel CAR T, they can be detectable up to 2 to 3 years in some patients. In ide-cel case, it's usually a lesser, shorter persistence, maybe typically around 3 to 12 months. And then I know that we will be talking later on about the new product, the new kid around the block. This is ide-cel anito-cel. So this is the new BCMA CAR T product, and that demonstrated also a persistence beyond 1 year. I think it's important to remember that the efficacy from CAR T in myeloma does not always depend on persistence. And we have patients in whom CAR T are not detectable after a few months, and yet they are in deep and sustained response. So one of the main factors in multiple myeloma in terms of CAR T efficacy, it's actually the depth of response that is achieved early on with CAR T treatment rather than persistence.
How many times can a patient get CAR T cell therapy if they go out of remission?
Yeah, that's a wonderful question, by the way. And I know my answer may not be relevant even in a few months, but what we have right now is that with those two CAR T products that we have available commercially, right? And that's Cilta-cel or Carvykti and ide-cel or Abecma, the way they are covered right now is that you can have just one commercial product. However, the rule doesn't necessarily apply to investigational CAR T. And some of you may have had this experience that during the times when CAR T were still in clinical trials, you received one of these products, ide-cel or Cilta-cel, being on trial, and then had a response. Let's say you relapsed. And by the time you relapsed, both Cilta-cel and ide-cel were already approved as commercial products, and you were able to receive another product, either Cilta-cel or ide-cel, depending on what you received before. And you still had a response to that. I personally have a patient who received anito-cel on a clinical trial. They were in remission for about a year or so. They relapsed, and by the time they relapsed, Cilta-cel was approved, and they received Cilta-cel, and they had another remission for over a year. The other scenario is that after relapsing, after standard of care, commercial CAR T, right, ide-cel or Cilta-cel, you may be offered an investigational CAR T on a clinical trial. That usually happens when there are clinical trials available with CAR T targeting a different receptor, a different protein on the myeloma cells. And here's an example. Let's say you received ide-cel or Cilta-cel as a commercial product. You had some response. You're relapsing, and there is a clinical trial involving a GPRC5D targeting CAR T, which is arlo-cel. And we have that available here at MGH. So we have patients who relapsed after ide-cel or Cilta-cel, and they are now on this trial with GPRC5D targeting CAR T. So while, it's not a standard practice at the moment to have a second CAR T, I do think that in the future we'll have that option.
Is it safe to get vaccinated for COVID, flu, and RSV after CAR T? What else can I do to avoid infection?
Yeah, wonderful question. Again, it is generally safe. And it's actually strongly recommended, acknowledging that the immune response to vaccine may be suboptimal after CAR T. So there was a study actually that reported that 31% of infections after BCMA CAR T were preventable. And that basically underscores the importance of trying. So we usually recommend the vaccination with COVID, flu, and RSV in about 1 month following CAR T. Additionally, the International Myeloma Society has created guidelines for prophylaxis, meaning for prevention of infection. And those include pre-infusion screening for various viral infections, for example, for HIV, for hepatitis, right? And often we've been screening for COVID. Then once you get the CAR T, you have to be on antiviral prophylaxis, and that's to prevent herpes simplex, right? Or zoster. And then prophylaxis for pneumocystis pneumonia. Many of you are probably familiar with either Bactrim or Dovacon. And an important part of kind of supplementing your immune system post-CAR T, because one of the very common complications of CAR T is hypogammaglobulinemia. So an important part of supportive care is the supplementation with IVIG that we often do on a monthly basis, sometimes regardless of the IgG level. Depends on what are your local insurance covering. And then, the basic things, right? Minimize the exposure to infections, like just, follow good hygiene, avoid sick contacts, consider prophylactic antimicrobials if your neutrophils are low.
Next question is for Ms. Franzetti. How long does a patient need a 24/7 caregiver after CAR T-cell therapy? And what specifically are caregivers expected to do after treatment?
So great question. It really varies. Just to start, it's different depending on where you are being treated. So for a long time, the FDA had something called REMS, which is basically that they had a national guideline as to what they considered safe. It used to be very strict in terms of the monitoring and in terms of how long you needed a caregiver and couldn't drive for. So those guidelines or those standards have changed recently in June of this year. So there are still official instructions for the treatment that are part of the product label that are determined by the pharmaceutical company. So that label could vary from the federal guidelines, but that label says, whether patients need to be closely monitored for 2 weeks or 4 weeks. And so regardless of what the label in the federal government says, it's a matter of what your institution says. So, depending on, again, where you receive your care, that the hospital has its own set of policies. So some institutions may say you still need a full-time caregiver for 28 days post the infusion of your CAR T-cell therapy. And others might say, no, you only need it for 2 weeks. So the biggest thing is just speaking with your healthcare team, but it can vary somewhere between the 2 and 4 week period. When it comes to what a caregiver actually does, it's the second part of this question, but they are really your safety partner in the process. So their job is to not necessarily provide you with medical care, right? But to be your eyes and ears to notice if after you are discharged from your inpatient stay, or, if you are receiving care outpatient, when you're not underneath the observation of your healthcare team, when you're home, for your caregiver to notice if you're developing any confusion, trouble speaking, fevers, if they notice any of those symptoms, to just make sure that they contact your healthcare team for you. So they're there to also assist with transportation, again, for as long as you're not able to drive post-treatment. And they're also there to be, the pests that are reminding you to stay hydrated, or, to engage in things that bring you joy, whether it's watching, a TV show that you find, that's enjoyable to you, that's funny. or, trying to read a book, but to just be someone that's there to engage and support and encourage you.
I live alone and lack social support. I may not be able to find a caregiver. How have others dealt with this situation?
So you're definitely not alone. Many patients face this. Not everybody has a spouse or a partner or a family member that's nearby or can fly up or, over from wherever they are to step into that role. I've seen a lot of patients get creative, and in my role as the oncology social worker with the CAR T team, and for most CAR T-cell therapy centers, you will have a social worker available to you. They're there to help you with also getting creative. And at the very least, if you don't have a social worker available, you'll have a nurse navigator available to you. But so getting creative can look like, maybe it's leaning on a family member that can give you a handful of hours per week, and then leaning on a neighbor that can give you another handful of hours. Now, of course, we want you to minimize your exposure to different people as you are in that vulnerable state post-treatment, but sometimes it is a little bit of putting pieces of the puzzle together. Some individuals will hire a home health aide for a period of time. Depending on where you live and the type of insurance that you have, maybe what you may be able to receive a home health aide through your insurance. However, that is very limited, and it's typically only restricted to the state insurance programs. And even then, it's not a full-time caregiver situation. They would be there to be able to provide some level of support in fulfilling the caregiver role. But the biggest piece of advice too is reaching out to your social worker or your team in general to ask, are there different ways to problem solve here? Because you could lean on, or they can help you leaning on community-based organizations, volunteer organizations. These things are limited, but there are some available depending on where you live.
Okay, the next question talks about resources. At BMT InfoNet, we have a Caring Connections program with the peer support, and what sort of resources are available to help CAR T-cell therapy patients and caregivers with expenses?
Yeah. So, and Michaela, I'm a big fan of the peer support resources. So BMT InfoNet's Caring Connections program, Blood Cancer United had also, or formerly known as Leukemia and Lymphoma Society, Cancer Hope Network. There are a bunch of different community-based resources where you could speak to another patient who's been through CAR T, around the same age, who, also has, let's say, diffuse large B-cell lymphoma, who also received Breyanzi, to see, hey, how did you feel post-treatment? What were the guidelines from your institution? And what did you do? Did you also have trouble with finding a caregiver? And what, how did you find financial assistance with that? So leaning on those peer connections and finding education in that way can be really helpful. I like to put it this way when asked about the financial assistance resources for caregiving support, they're limited. So I say it's about sort of robbing Peter to pay Paul in some way. So, there are lots of organizations that will provide general financial assistance. So, just to use the Blood Cancer United, they have a patient aid program. If you haven't tapped into that resource yet, it's one time only, but that one, for example, is $100. Which isn't much, right? I understand that. But so you could use that towards, let's say, whether it is the home health agency and paying for a caregiver, or whether it is to, just help offset the overall financial burden of treatment. And that way you could spend that money that you would have spent on a caregiver and put it towards, use the money that you would have spent on, let's say, like your gas bill for the month, and put that towards the cost of a caregiver. Some states have a program called family leave insurance. So I believe there are only 12 states with that. And you can easily Google that and just find out if your state has family leave insurance. But if your caregiver is somebody who is working and needs to take time off to be your caregiver, they may be eligible for family leave insurance. It would be only a portion of their household income or of their typical salary, but that could help with the cost of being out of work for some time. And beyond that, you never know also too if your institution provides some level of assistance. Those are just sort of the types of things. And of course, I want to also plug that BMT InfoNet has a really great financial assistance program that depending on available funding and all that, you could apply for it. The only thing with that program is just to keep in mind that you wouldn't be able to apply, or your healthcare professional would not be able to apply until the day that you receive your cells. So it would more so be like a reimbursement, or you would use that funding that you spent out of pocket for a caregiver. And, just whenever, if you are approved for the BMT InfoNets funding, you could receive that and on the back end of things. And then the last part of this question, just in terms of expenses, is that the pharmaceutical companies have different support resources. So the programs through the pharmaceutical companies do not offer financial assistance with the cost of a caregiver. However, they can help with the cost of transportation, of meals, of lodging. It varies based on, your eligibility. And so just, the best thing to do would be to reach out to your care team and ask, hey, are there any resources available to me? Reach out to bigger organizations like, BMT InfoNet, like American Cancer Society, like Blood Cancer United, and ask, do you know of any resources available?
CAR T-cell therapy patients?
So currently there is a support group, I should say, or we just recently ended this cycle of the BMT InfoNet's CAR T-cell therapy support group. It is the only one in the country that's advertised, so which is really, really exciting. And I've been the facilitator of that. We've done about 4 cycles of that group. It's a 6-week cycle, and it is just the most engaging and warm network. So hopefully, and I'm sure we will do another cycle of that again. If not, if let's say you can't find a group near you, or let's say, you don't want to wait for the next cycle through the BMT InfoNet to start up, I recommend contacting, I'm going to say it again, I'm going to sound like a broken record, but asking, your oncology social worker or your nurse navigator for information on CAR T support groups if they're aware of any in your area. If there aren't, you could also do individual peer support, not a group, but individual peer support through the BMT InfoNet Caring Connections, through Blood Cancer United's, Patty Eric Kaufman peer support program. Again, there are a whole bunch of them, just to speak to somebody individually, and you can get multiple connections as well. And then there are some online forums, depending, on what resource you use. I always say be careful with those, because you want to make sure that if you do search for an online support forum, that it's one that has a moderator through a reputable organization, and not just, let's say, like a Facebook group, because I've heard stories from patients where there wasn't any monitoring going on. And the best part of, having a support group is that you're able to vulnerably share and find the encouragements as well. And so having some level of structure around that is what helps to make the group thrive. So unfortunately, only one that we're aware of right now in terms of how many support groups, but there are plenty of resources.
Great. Thank you, Maggie. Our next set of questions are about CAR T-cell therapy for patients with multiple myeloma, and I'm on maintenance therapy. Should I consider CAR T-cell therapy now, or wait for new developments in CAR T-cell therapy?
Yeah, so I don't think there is a one-size answer here. And I think it's important to go back to the labels, right, for these 2 CAR T products that we have approved in multiple myeloma, which are Sylvester and ide-cel. Why? Because although initially both of them were approved in late relapse in myeloma after 4 lines of treatment, so basically in heavily pretreated patients, now based on 2 phase 3 trials, specifically KarMMa-3 and CARTITUDE-4, these products, meaning ide-cel and Sylvester, are approved in early lines of therapy, right? So we have Sylvester as early as after 1 line of treatment in patients who are relapsing on lenalidomide maintenance. And then we have ide-cel approved after 2 lines of treatment, where patients received daratumumab, Velcade, and Revlimid. So what I'm trying to convey here is that none of these labels include maintenance, right? So you'd have to have some sign you'd have to show some signs of relapse. And it doesn't have to be a clinical relapse, meaning it could be just a biochemical relapse. The M protein starts going up, right? Light chains start going up. That would be a reason to consider CAR T. And then I guess the question is more like, so should I consider CAR T in early relapse as opposed to later on, right? And maybe think about some other standard of care options. So I think by now, right, based on clinical trials and real world data, we have a lot of data suggesting that it's better to use CAR T earlier in the course of the disease. And it's not just because there is such an encouraging efficacy, right, that we saw with those CAR T4 and KarMMa-3 trials, but also because early on your T cells are fitter and more robust, and there is more chance that you'll get kind of a healthier CAR T product and a more robust CAR T product. Another factor is that you have a little bit more bone marrow reserve at the beginning, right? Because once you are through a few lines of treatment, unfortunately, one of the complications is persistent bone marrow suppression. However, there is always a caveat, right? And because what we've learned now, based on our cumulative experience, is that there are certain side effects with, specifically with Cilta-cel, right, like delayed neurotoxicity and second primary malignancies. That's a question, right, that always comes up. Are you ready to take that risk? And this is where it's so important to sit down with your oncologist and think about the risks, benefits, and just, decide for yourself. What is the extent of the risk you are ready to take? Because obviously the success rate with either Cilta-cel or ide-cel is significant and could offer a remission for many years. Now we know that with CAR T1, at least a third of patients are in remission for over 5 years, which is pretty amazing.
I had a stem cell transplant for myeloma, which wasn't successful. I didn't achieve remission. Is CAR T therapy likely to get me into remission?
Yeah, so when I see patients with suboptimal response to transplant or an early relapse after transplant, right, within a few months, 6 months, even 18 months, so all those are considered features of high-risk disease. And what we learned so far is that both Cilta-cel and ide-cel have shown a pretty strong potential to induce deep responses in patients with high-risk disease when compared to standard of care regimens at the same, let's say, stage of myeloma course. And another, I'd say, trial, right, that actually looked at patients with suboptimal response post-transplant involved ide-cel. And this is KarMMa-2 trial. And what the trial looked at is whether having ide-cel post-transplant in those patients with suboptimal response, where that would bring those patients, right, into remission and keep them in remission. And what we learned is actually with ide-cel, those patients who didn't respond well to transplant, right, achieved an 87% of overall response, and 77% were complete responses, which is pretty amazing in patients with high-risk disease. And then the median progression-free survival, right, which is the period where they were able to stay free of disease, was even not reached at nearly 3 years of follow-up. So that's pretty encouraging. So that's basically telling us that, yes, using, at least in this trial, right, ide-cel post-transplant patients who either had a suboptimal response or have a biochemical relapse, it's a very solid option, therapeutic option. With Cilta-cel, we didn't have a similar trial, but we do know based on CAR T4 and real-world experience that Sylvester is capable of achieving response in patients with high-risk disease. So the answer is yes. CAR T is definitely an option for patients who are relapsing after transplant. And again, the question is, what is the risk that the patient is willing to take when thinking about safety and long-term toxicities?
How successful is CAR T-cell therapy for high-risk myeloma patients?
Yeah, so this seems like a natural follow-up to the previous question, right? Because when we think about high-risk disease, while post-transplant early relapse is one category, another category is patients with high-risk cytogenetics, right? For example, 17p deletion or gain of 1q or 1p deletion. And then another category of high-risk patients in myeloma are those who have extramedullary disease. So the good news is that in both earlier trials like CAR T1 and KARMA that evaluated CAR T in patients who were heavily pretreated. And in those trials that evaluated CAR T in early lines of treatment, right, in less heavily pretreated patients, but still some of those had high-risk features. Both CAR T products were successful. The problem with high-risk disease is that while you achieve a response, it's not durable. So what we learned is that patients with high-risk disease, unfortunately, they relapse faster. They may respond, but they relapse faster. However, right, that gives us that window where we can control the disease and we can think about the subsequent therapy to deepen the response.
Does CAR T therapy work for patients with AL amyloidosis?
I love this question, right? Because it's like siblings, patients with amyloidosis and myeloma. And by the way, in about 5 to 20%, those two overlap in patients. So we have patients who have both myeloma and amyloidosis. So to answer this question, we have emerging data that suggests that, yes, it's a very promising therapeutic option. There is actually a phase 1 trial that was done at Memorial Sloan Kettering Cancer Center. And they looked at a BCMA-targeted CAR T therapy in patients with amyloidosis. It was fairly small, right? It's an early phase trial. But 8 out of 9 patients who were tested for residual disease, right, show no presence of disease, meaning no presence of clonal plasma cells. And that was very, very encouraging. On the other hand, CAR T was pretty well tolerated. And then so that's one right piece of information. The other one is that in those patients who have coexistent myeloma and amyloidosis and received CAR T, what we learned is that it's relatively safe. Obviously, it depends on the degree of renal involvement, of cardiac involvement would be probably tougher to get patients who have extensive cardiac and kidney involvement, right, through CAR T. But otherwise, it's doable and it's pretty efficacious because, you have to remember in amyloidosis, we have a very small population of clonal plasma cells. So the disease burden is very low. It's all about to what extent we have end organ damage and whether we can get our patients safely through CAR T. So yeah, the data that we have so far is promising.
I have multiple myeloma and had a CAR T-cell therapy in July of 2025. I'm experiencing severe weakness, fatigue, poor coordination, and low red blood cell counts. Although I have trouble staying awake, I also can't sleep for long periods of time. Will these problems subside at some point?
Yeah, so many patients after CAR T therapy experience lingering side effects, and those are low blood counts, right? That can manifest as fatigue. There's also this phenomenon of chemobrain, where patients are a little bit foggy and don't feel like they can focus well. There are some neurological subtle issues, and I'm not referring to delayed neurotoxicity. Also sleep issues. So all of those, technically within 3 to 4 months, should improve. If they don't, I think the question that has to be discussed is, are those a form of delayed neurotoxicity? And delayed neurotoxicity is a phenomenon that we saw mostly with Sylvester, less with ide-cel. And those are Parkinson-like symptoms, or those, is this change in affect, change in personality, symptoms that could be sometimes subtle, but if involving a neurologist and the diagnosis becomes clear, the treatment would be steroids and certain agents that reverse that inflammatory process in the background. So what I would suggest, right, if these symptoms persist and they don't improve, because within 3-4 months after CAR T, one would expect the symptoms to get better unless you have persistent anemia, right, or you have recurrent infections that contribute to that. So if that happens, I would suggest discussing that with your primary oncologist and seeking neurological evaluation.
All right, our next set of questions will pertain to CAR T-cell therapy for lymphoma. Dr. Spiegel, I have mantle cell lymphoma. When I relapse again, I will be looking at either CAR T-cell therapy or bispecific antibody treatment. What are the pros and cons of each?
Yeah, yeah. So that's a very relevant question. I think the field is really going to be discussing that for the next several years. Currently, in mantle cell lymphoma, I think the paradigm is currently CAR T and then bispecifics after, though that might be changing by the time this becomes relevant. There are 2 CAR Ts that are approved in mantle cell lymphoma. One is called Brexucell. It's a CD28 based CAR T therapy, so it's a little more of a wild ride, I would call it, versus Lysocell, which has recently approved for mantle cell lymphoma, 4-MBB, a little more gentle, typically associated with less toxicity. We have more follow-up with Brexucell, so I think until very recently, most people would be defaulting to that, but tends to have high rate of neurotoxicity, and I think some of the real-world data has shown that there is some higher non-relapse mortality associated with that product. That said, based on the clinical trials that we have, which is very, again, hard to compare because there's slight differences in the patient population, it does appear there might be a longer time in remission and longer overall survival for those patients relative to Lysocell. And that's a little hard to tease out if that's something that would be relevant for each individual patient. Now, as that compares to the mantle cell lymphoma bispecific, so bispecific, as opposed to a CAR T, which we discussed, we have to take out the T cell and manufacture it into a CAR T cell. A bispecific just leverages the immune system as it is. So it has 2 arms. One latches on to the lymphoma, one latches on to the T cell, brings them close to each other. So I saw on Twitter, and I forget who it was, but he called it Tinder for the immune system. So just think of it as the best way. It's putting the immune therapy where it needs to be. Now, in mantle cell, as opposed to some of the other subsets of lymphoma, like follicular lymphoma, glofitamab, which is the main agent that's come closest to being widely used, though it is widely used now in the clinic, does have a higher rate of toxicity, particularly CRS, and even high-grade CRS. So patients are admitted for at least the ramp-up phase of glofitamab treatment. And in the trials, the rates of high-grade CRS, so that's low blood pressure requiring special supporting medicines, is up close to 10%. Now, a lot of centers are moving towards using preventative medicines to reduce rates, and I think we'll see real-world data that shows that that's effective. So I think that might be less of an issue going forward. But the toxicity profile from the cytokine release syndrome perspective is still higher with bispecifics and mantle cell than with other diseases. The rates of neurologic toxicity are less, and I think importantly with mantle cell lymphoma, they can be significant, particularly with Brexucell. Patients can remain hospitalized for higher periods of time. I think that's related to the type of disease that people have when they enter CAR T therapy. I think across all diseases, ALL, myeloma, lymphomas, higher disease burden is associated with less efficacy, but also higher toxicity. And I think mantle cell lymphoma, which often has a bone marrow component, a component circulating in the peripheral blood, can be associated with these toxicities. So I think another thing to consider when you're going into the disease process for either of these therapies, where is the disease and what is the burden of disease? And that will really dictate what type of toxicity you may be at risk for experiencing. As far as the differences, otherwise, bispecifics are given in an ongoing fashion, but outside of that initial hospitalization, those tend to be outpatient. They both have risks of infection, which we mentioned, but CAR T might be a little bit more. Some of it comes down to ordering. I think, because we don't think that mantle cell is necessarily a curable disease, but more of a disease that will require multiple lines of therapy. I think ultimately many patients will receive both of these types of treatments, and it might just be a question of in what order.
If I undergo CAR T-cell therapy to treat my lymphoma, what will my quality of life be like? I am worried about having a suppressed immune system. I have preschool-age grandchildren who are often sick with cold and flu illnesses.
Yeah, so I think that's certainly very relevant. There have been some patient-related outcome studies, and I think with the lymphoma CAR Ts, there is certainly impaired quality of life after the CAR for about 28 days for sure, and then some recovery over the next several months. A lot of that is really dependent on how much toxicity you experience. If you have a little bit of fever and not much in the way of neurotoxicity, I think people can get back pretty close to normal by the end of the first month. If you have grade 3 neurotoxicity, end up in bed for a week, getting steroids, that recovery will certainly be prolonged. So I have patients that are working within a week of getting out of the hospital. I have, just patients that got out recently. One gentleman went right back to work, even though I told him not to, but anyway, he went back to work. He's fine, totally fine. And then I have a patient that, had significant neurotoxicity that lasted a long period of time, and he's still getting back on his feet, had to go to rehab after. So there is a wide range of what patients can experience, and it really depends on burden of disease and what toxicities you experience. As far as the infection-related question, you will have an suppressed immune system. We know that, as Dr. Cirstea mentioned, patients will have low B cells, which produce antibodies. So they will have low antibodies that they produce. Sometimes we supplement, depending on the person. I tend to only supplement once patients get an infection and they have low IgG, but that is not something that's defined. I think it really varies by center. And even the vaccinations that Dr. Cirstea mentioned, that approach really varies by center as well. The school-age grandchildren is really, I think, a risk-benefit ratio, during, like everything in life, honestly, but, during the first month, I tell people to be very careful, and then kind of depending on how they're doing, they can slowly expand the circle of who they're willing to bring into their lives and, what they're willing to do. So for example, in Miami, it's a little easier. when it's winter outside, I tell people it's easy to meet people outside, right? Outside really reduces the risk of transmission of infectious diseases. Obviously, in the northern United States, and I'm from Canada, that wouldn't be very possible. So I think you have to consider a group of people that you trust. If they're sick, stay away, obviously, as mentioned. But, you know, I always tell people, you go through this therapy so that you can enjoy your life. So to tell someone, don't see your grandchildren for 6 months, to me, that's a little bit difficult. So I think certainly within the first month, I tell people to be very careful. And then every person, I gauge, you know, what their infection process has been and, you know, whether we can loosen that up little by little. But I think patients, you know, you also have to consider patient quality of life from that perspective. Seeing your grandchildren, I think, would be very important.
What is the longest remission that's been seen for mantle cell lymphoma patients who undergo CAR T-cell therapy?
Yes, that's a good question. Like I mentioned, the initial Brexacell study, which is called ZUMA-2, probably has the longest reported follow-up with remissions lasting just under 5 years. We don't have really more data than that. The overall study showed that patients remain in remission median, meaning 50% do better, 50% do worse, is about 2 years, and the overall survival is about 4 years. With the Lysocell study, the median time in remission is about 15 months, and the overall survival is closer to 2 years. But again, differences in patient populations, it's hard to directly compare.
I have relapsed mantle cell lymphoma. I also have new onset ITP and was told I could not get CAR T-cell therapy. My platelets are stable on Promacta. Is CAR T therapy still a treatment option?
Yeah, so I would say the short answer is yes, but it's obviously a little more complicated than that. What with mantle cell being a bone marrow-based disease in many cases, I would want a bone marrow biopsy first to rule out involvement by mantle cell lymphoma, but then also to look for other types of diseases that can be in the bone marrow. So for me, ITP would be a bit of a diagnosis of exclusion. Mantle cell lymphoma can cause an enlarged spleen. So there are lots of causes for low platelets that I think need to be investigated, namely mantle cell lymphoma, but second, cancers. You know, if a patient has received chemotherapy for their initial treatments for mantle cell lymphoma, I think also need to be considered. Now, Dr. Cirstea also mentioned that low blood counts is a significant issue after CAR T. I think probably a little more with myeloma than with lymphoma, but still. So there is a score called the CAR Hematotox score, which was developed by Dr. Kai Rajeski, and they actually have an online calculator with very easy to calculate based on clinically obtained blood tests, and that can actually give you a projection of what your low blood counts might look like after CAR T therapy. So I would say most patients will have their low blood counts resolve within 2 to 3 months after therapy with lymphoma. About a quarter of patients may require a blood or platelet transfusion, but then, you know, the majority do not. But it really is all based on how you come into CAR T therapy. So if you have low blood counts, low platelets, I think it really depends on what that level is. On Promacta is great. We could continue that after, and there is some data for using Promacta for low platelets in the post-CAR T setting, but it really depends on the level, and then looking at the CAR Hematotox, and then how you'll manage the Trombopag or the Promacta after the therapy.
Okay, our final set of questions will deal with what to expect after CAR T-cell therapy and what the future holds for CAR T-cell therapy. Dr. Cirstea, are there other diseases that may be treated with CAR T-cell therapy in the future?
Yes, the future is very active, and I'm so looking forward to what's coming up. So as we said, beyond myeloma, we are learning how CAR T can be used in amyloidosis, and I think this field will keep moving forward. And then there are the hematological malignancies, apart from lymphoma, that Dr. Spiegel nicely outlined. It's being used in chronic lymphocytic leukemia and also in AML, but all of these are still in clinical trials. Also, there are clinical trials looking at CAR T in solid tumors, but it seems like this is a little bit more challenging, maybe because of the difficulty of penetration by CAR T into the solid tumors. And that could be maybe an issue that will have to be overcome. Also, there are so-called CAR NK cells that are being tested in solid cancer, where you use not your T cells, but NK cells to make CARs. And then non-cancer diagnoses, right, like autoimmune diseases, where CAR-like cells, right, may delete specific immune clones. And for example, CARs targeting CD19 could be used in the autoimmune disorders that are driven, right, by B cells producing these antibodies that attack your own tissues. You know, I think that this will only keep evolving and growing. So I think there is a lot of hope. And as long as we have courageous patients who are willing to be on the trials and who trust us, and I'm deeply thankful to them and their families and their caregivers, I think we'll be able to push the field forward.
Dr. Spiegel, what are the pros and cons of using donor T cells rather than a patient's T cells to make CAR T cells for a patient?
Yeah, so I think this was a very exciting frontier that the field was looking at several years ago. I think there are multiple pros in terms of, you know, we've talked about patients' T cell fitness after all these lines of therapy. You know, you think we use T cell exhaustion as a medical term, but, you know, I think it's very evocative. You've been through lots of therapy. The T cells have been trying to fight the cancer. Maybe they're not able to keep the fight up anymore if we try to supercharge them as CAR T. Also, a CAR T doesn't require any of that time for manufacturing. You just go, reach off the shelf. It can be the, you know, super marine CAR T cells, and it really can give quick therapy and very effective therapy. However, I think what we found out through multiple trials is that the immune barrier is actually quite strong, and that these donor cells don't really stick around very long. And as such, I don't think the data really supports their use currently as a replacement for autologous T cells. So there are many trials looking at different ways to change the T cell to avoid being rejected by the host immune system. So your immune system isn't strong enough to fight the cancer, but it's still strong enough to fight off these donor T cells that we put in. So I think at the moment, this approach is not ready for prime time. And I have some suspicion that without significant changes, it won't.
Thank you. We do have a couple more questions left, a little bit of time left. This is a question for Dr. Cirstea. How does cilta-cel Carvykti compare to anito-cel to treat multiple myeloma? When will anito-cel be approved by the FDA?
Yeah, so I'm also looking forward to that because I love anito-cel, by the way. So it's important to remember that these two CARs, they target the same receptor, right? BCMA. However, cilta-cel has basically two warheads, right? And it attaches to two BCMA epitopes on the myeloma cells. So it has kind of almost like a dual attachment. On the other hand, anito-cel has an engineered synthetic D domain that just makes it a little bit more persistent and avoids, let's say, the production of the antibodies by the host against the CAR T cells, right? That can happen with other products. So it's just a better design in terms of the persistence and the attachment to the myeloma cells. Okay, so what do we have so far? We have a lot of data on Sylvester. We know it works. We also know that there is some toxicity with that. And we're always very careful when we decide to deploy it. With anito-cel, at ASH, we had phase 1 and phase 2 trials that have been reported on anito-cel. In phase 1, the response rate was 100% in patients who received anito-cel. And the median progression-free survival, again, right, that's the period where you are disease-free, is almost like 3 years, so very comparable to Sylvester. The beauty of anito-cel is that we haven't really seen any delayed neurotoxicity. So that's a big plus. And with that in mind, now we have the phase 3 clinical trial that's comparing anito-cel to standard of care regimens in patients in early course of their myeloma, right, after 1 to 3 lines of treatment. And this will be the registrational trial. So the hope is that, right, that maybe in 2026, we'll see some sort of light in the tunnel in terms of the anito-cel approval.
Okay, this is a question for Dr. Spiegel, our last question of the evening. What is in vivo CAR T-cell therapy? Is it likely to be safer than the current type of CAR T-cell therapy?
Yes, that's a great question. So in vivo CAR relies on some of the mRNA-based technologies. I know it's a loaded term these days, but it relies on some of that technology that we leveraged with some of the COVID vaccines, where we can actually deliver the genetic DNA that actually makes the CAR during the manufacturing process. We can inject it or infuse it into the patient and create the T cells actually without doing any sort of extraction process. So we put in, these mRNA, they're protected through various mechanisms. They can actually get into the host T cell and just create the CARs kind of right there. It can avoid some of the issues that we've already talked about that people thought donor T cells would avoid, like time to manufacture. It can also be off the shelf, easily just administered right away. The question is about persistence, and also, it can avoid perhaps some of the thought that we can generate T-cell cancers with the CARs, which we didn't touch on, and I don't think is really a massive problem, but it is a small problem that we have noticed. It might avoid some of those problems as well. That said, still very early phase. We don't know whether the CRS or neurotoxicity will be less. I think that's really going to play out over the next 2 to 5 years. I think that might be the next frontier rather than the donor cells, but still very, very early days there.
Well, I'm afraid we're out of time this evening, and thank you again to all our expert panelists for sharing your knowledge, your expertise, and the time with us tonight. And thank you to the audience for your excellent questions. Have a wonderful evening, and please if BMT InfoNet can help you in any way. Take care.